And we move on to the third talk with our patient. And in this, I'm going to talk a little bit about when to give intravenous fluids and hopefully make some distinctions between the often muddied and confounded notions of volume status, volume responsiveness, and volume tolerance. So it's the same case, community-acquired pneumonia with some subacute chicken soup-induced cardiogenic pulmonary edema. The patient is obese. She was wheezing when she came in with the elevated BNP and elevated lactate. We didn't give her any fluids in the last presentation because of that mildly elevated lactate. She received the cocktail. She got the angiogram, CT angiogram, which we may recall looks like this. This time when you see her the next morning, her urine output is diminished and her creatinine is risen. So your keen house officer performed a passive leg raise with an aortic outflow velocity time interval monitoring and found a significant augmentation, noting that she is therefore fluid responsive. So the question is, what should you do about her diminished urine output and rising creatinine and the positive passive leg raise? So obviously you need to give her more fluids because A, she's got the elevated lactate, B, she's got sepsis, and C, she's fluid responsive. So the answer to that is no, you wouldn't do that. So the objectives for this talk is to appreciate the difference between volume status, volume responsiveness, and volume tolerance. These are clinically, colloquially often interchanged and frighteningly often in peer-reviewed journals articles. I see these used interchangeably, which I find mind-boggling. In any case, we're going to talk about the physiological underpinning of volume status, volume responsiveness. And then I'm going to describe my schema for organ-specific volume tolerance. So let's tease apart these two things: a patient's volume status, which I'll refer to as just kind of generally as the patient's overall blood volume, and generically split it into three as a patient being hypervolemic, euvolemic, or hypovolemic. And also volume responsiveness, which means that a patient will augment their stroke volume or cardiac output in response to increased preload. So we're going to start with this idea of the venous capacitance bed. So let's say this is your venous system lumped into one water bed here, and 70% of your blood volume lies in your veins. So there's a pressure that's generated on the walls of this water bed. It's an elastic recoil pressure. And it is generated from the stressed venous volume, and that elastic recoil pressure is known as the mean systemic filling pressure, and it's the pressure head pushing, for lack of a better term, venous blood towards the heart. So this process here is known as venous return. And then what the heart does is it takes those parcels of blood that it's receiving for the venous beds, and then it ejects it into the stiff arterial tree, and the arterial tree is about 30 times less compliant than the veins. So every parcel of blood that the heart receives from the veins and then ejects into the arterial tree, the pressure is roughly 30 times higher in the arterial tree. And then the pressure gradient from the arterial tree back down to the veins, round and round we go. So as I mentioned, this was venous return and this is cardiac output, and I'm going to describe these two general phenomenon together on the Guyton curve in just a moment. So let's say that we stop this heart and we let all the pressures equilibrate. What would happen? Well, the blood volume in the high pressure arteries would partition its way down into the veins, and everything in all of the chambers of the heart, the arteries, the capillaries, and the veins would assume this mean systemic filling pressure. So the mean systemic filling pressure, as I mentioned, is that elastic recoil pressure, that pressure that's pushing out against the walls of this lumped vascular system. And as I mentioned before, it's sort of like a waterbed. And if you imagine filling a waterbed with water, you actually have to give the waterbed many liters of water before there's any pressure imposed on the wall. And that would be the unstressed volume. And the vast majority of the blood volume is actually unstressed. It's only a small proportion that's actually stressed that's causing that recoil pressure. So what does this have to do with volume status? Why do we need to understand this? Well, if you were to give this patient 3 liters of crystalloid, you'd increase the blood volume, increase that mean systemic filling pressure, or the stressed volume, and the recoil pressure, which would then augment venous return to the heart. Similarly, if you were to shrink the blood volume, relative to the container size, you would diminish that mean systemic filling pressure and you'd lower the venous return. And so all of those processes can be demonstrated on the venous return curve. So this was originally given to us by Dr. Arthur Guyton many decades ago. And this is the venous return curve. So this is blood flow towards the right heart on the y-axis, and on the x-axis, this is the downstream pressure or the right atrial pressure. And this key point here, this x-intercept here, is that pressure in the waterbed, the mean systemic filling pressure. So that's the pressure that's, for lack of a better term, pushing venous blood towards the right heart. So you can see from this upstream pressure, as the downstream pressure falls, the amount of blood flow is increased until it meets this maximal venous return, which is essentially when a Starling resistor is generated at the thorax. And so again, mean systemic filling pressure here. In that cartoon, when I showed the volume being infused into the waterbed and then increase in pressure, you can imagine that it would shift rightwards, and therefore for every given downstream pressure, the amount of blood that's returning to the right heart is augmented. So I'll call this increased circuit function or the expanded waterbed. And so good causes clinically would be you infuse some crystalloid into the patient, but also, and very importantly, adrenergic tone is a very potent mediator of the mean systemic filling pressure. So if you're hypoxemic and you have this intrinsic adrenaline infusion running, what the alpha receptors do, alpha stimulation, is it recruits unstressed volume into stressed volume. And this is actually a main compensatory mechanism during hypovolemia, where you can bolus yourself, I believe, in the human up to 20 cc's per kilogram just from compensatory responses. So certainly exogenous adrenergic agents will do the same thing to the mean systemic filling pressure. Conversely, you can have decreased circuit function, like if you lost some volume from the venous beds, but also, and very importantly, if you give a patient sedatives or alpha antagonists, like alpha blockers, but also the venodilation of sepsis, all of those things will lower the amount of stressed volume and de-recruit stressed volume, which will lower the pressure head for venous return and decrease the amount of venous blood returning to the right heart. So all of these things can be working in parallel, and there can be multiple mechanisms in any one patient at any one time. And indeed, it is almost certainly in every sick patient multiple mechanisms that are driving venous return up and down, which is critical to understand when interpreting the central venous pressure or IVC volume. So again, we just talked about venous return here. That was the Guyton graph we just saw. But the other half of the equation is cardiac output, which is just as important, pumping blood into the arterial tree. And so the cardiac output is given to us by the Frank-Starling curve here. And a crucial point here is that the slope of this curve is determined by much more than just contractility, which seems to be what everyone comes away with from medical school. Anything that increases cardiac output or forward flow for a given filling pressure will shift the curve up and to the left, and conversely, anything that decreases the amount of forward flow for a given filling pressure will shift the curve down and to the right. So, as I frequently say, it's a dumb curve. If you can imagine somebody with a very, very high left ventricular afterload, they would actually have a diminished stroke volume, so a fall in the y-axis for a given filling pressure. So a high afterload would shift the curve down and to the right, not just a decrease in contractility. And you can make the same thing for rapid dysrhythmias, valvular dysfunction. Anything that impairs forward flow for a given filling pressure is depicted by a down and rightward shift of the cardiac function curve. So that's what I just said. So let's imagine our 63-year-old patient that's coming in with a pneumonia and subacute chicken soup-induced pulmonary edema. So she's working extremely hard to breathe, as we saw in the last lecture, and in fact, that's probably why her lactate was elevated, is she has her own epinephrine infusion running because she's drowning. And so what that does is that whatever her baseline cardiac function is it's going to shift her cardiac function up and to the left. And to the extent that she has some sepsis-induced arterial vasodilation going on, that is some decreased afterload, that will also shift the curve up and to the left. So that could be how she presented. Similarly, things that shift the curve down and to the right would be an evolving septic cardiomyopathy, worsening afterload, as I mentioned, but also worsening fluid overload, right? As you dilate the left ventricle from too much fluid, you start to get functional mitral regurgitation. You start to increase the wall stress on the left ventricle, which raises the left ventricular afterload. rapid atrial rates will also shift the curve down and to the right. So you can see that this curve is incredibly dynamic, even within one patient over a period of minutes to hours. No static marker can inform you of the slope of this curve. You can see that this central venous pressure or right atrial pressure on the x-axis of 5, a CVP of 5, fluid non-responsive, a little bit more responsive, okay? So you could make the same argument with a horizontal cut as well. No stroke volume or cardiac output can tell you whether or not augmenting preload will augment forward flow as depicted on the y-axis there. So let's put the two together. We'll superimpose the venous return curve, which is that waterbed and venous blood moving towards the right heart, and then all of the determinants of cardiac function as depicted in the Starling curve. So where they meet is your central venous pressure or your right atrial pressure. So it's this balance point between inflow and outflow that determines the pressure in the right atrium, and importantly, the size of the IVC and your forward flow. So the question that I pose is, does a CVP give you your volume status? The answer is clearly no. The volume status is but one determinant of the mean systemic filling pressure, which is but one determinant of venous return, which is but one determinant of the central venous pressure. It is foolish to equate the two. Does the central venous pressure give you volume responsiveness? That is where you lie on the Starling curve. Where the venous return curve intersects the Starling curve? The answer is clearly no, as could be seen on the last slide, because it depends on the slope of that curve, which is highly dynamic and which is not readily accessible. There's the volume status, and there's the idea of volume responsiveness, the slope, where it intersects, okay? So the important thing is this CVP also applies to ultrasonographic assessments of the IVC. The distension of the IVC is determined by the central venous pressure or the right atrial pressure relative to the intra-abdominal pressure. If the CVP falls during inspiration, then the IVC will tend to collapse. Okay? So this is an analogy stolen from Sheldon Magder, that giving the CVP and asking a patient's volume status would be like giving the patient's pH and asking for the patient's lactate concentration. Lactate concentration is but one determinant of pH, but pH is far too complicated to make that correlation. So let's think about our patient. So we've got venous return coming into the right atrium and cardiac output going out of the right atrium, okay? So she came in with subacute volume overload with hypoxemia, and let's say that she had a very high stress response. So her venous return curve, you can see, we'll call this the euvolemic state with this mean systemic filling pressure, but she'd been eating a bunch of chicken soup, so she was volume overloaded, and she also had very high alpha adrenergic tone, which would shift the mean systemic pressure rightwards. So you'd expect her venous return to go up, and you would actually expect her central venous pressure to be high, but if that adrenergic tone was also, and that right shift of the venous return curve here is depicted as an increase in flow to the right atrium. But if simultaneously that adrenergic stress, her intrinsic adrenaline infusion, was driving up her cardiac function, right? So she had augmented forward flow, as depicted by an increased arrow here, you would actually have the same filling pressure because you have more inflow but more outflow. Same filling pressure, same IVC collapse, bigger volume status, probably same degree of volume responsiveness, but in this patient whose lungs are underwater, even though she's volume responsive, doesn't mean she needs volume. So let's say after a few hours, her clinical course starts to evolve. The furosemide that she received in the ED starts to kick in. She starts to urinate out volume. Maybe the furosemide is causing some venodilation, as was shown in the classic study by Dr. Dixit in the New England Journal of Medicine in 1973. Let's say septic venodilation starts to progress, so she starts to lower her mean systemic filling pressure, and let's say that you put her on some BiPAP, so her work of breathing and therefore her intrinsic adrenergic stimulus goes way down. So her venous return curve shifts leftwards for all of those reasons, that venodilation and the loss of volume. So you can see here venous return shrinks, but simultaneously her internal epinephrine infusion goes away from diminishing her work of breathing, and let's say that her cardiac function shifts down into the left to what might be a baseline diastolic dysfunction that she may have, and perhaps she's got some evolving septic cardiomyopathy at the same time. So now she's got diminished venous return, but diminished forward flow. And you can see here, it's actually the same filling pressure, right? Same degree of IVC collapse. But now she's much closer to the plateau of her Starling curve, such that giving her fluids could be dangerous. So in the cartoon above, you can see that the venous return is diminished and cardiac output is diminished. And therefore, you actually end up with a similar filling pressure to the other two states. And this isn't just fanciful academic talk. It's been documented to occur that a low filling of pressure in the right heart can be associated with a state of cardiac or fluid non-responsiveness. In fact, in a meta-analysis in critical care medicine in 2016, 40% of patients with a CVP of less than 8 millimeters of mercury were fluid non-responsive. Similarly, in a paper in 2007 by Magder, 25 to 30% of patients with a CVP of less than 5 were fluid non-responsive. So this sort of physiology does occur in critically ill patients. And here that red highlight of the slope of the Starling curve demonstrates that the venous return curve is now intersecting a fluid non-responsive state. So 3 different volume states, three similar central venous pressures, 3 similar degrees of IVC collapse, assuming that in all 3 states the patient breathes in to the same degree, but all with different cardiac outputs, all with different stroke volumes. And in each state, given what we know about this case, in all cases, you probably should not give this patient fluids. So that leads to this notion of volume tolerance. So if we consider fluid to be a drug, just like any other drug, there can be organ-specific adverse side effects. And there's always a risk to benefit ratio with any drug. So the power of ultrasound is that you can use ultrasound to assess the vital organs for their risk for further fluid loading. And then you want to give fluids when the overall benefit of fluids outweigh the risks to the various vital organ systems. So there needs to be some sort of clinical trigger for intravenous fluids when you're considering when to give fluids. And that's usually a drop in blood pressure or a drop in urine output, or sometimes a rising lactate, although I'll refer you to the second lecture of this series. And there needs to be some sort of pretest probability whereby you think augmenting preload will help this patient's stroke volume. So in order of importance of vital organs, the lungs are scientifically proven to be the most important organ in the body. So the first organ system that you have to assess for risk is the lungs. And for this, you look predominantly at the left heart, but you're not looking at the heart for the heart's sake. You're actually looking at the heart for the lung's sake. So there's a number of different ultrasonographic assessments that you can do, echocardiographic assessments that you can do to assess the risk of lungs, but you're looking for signs of pulmonary venous hypertension and interstitial or alveolar edema. So what might those be? Wide open mitral regurgitation, diastolic dysfunction as indicated by tissue Doppler, reversed E to A ratio, left atrial dilatation, poor ejection fraction. If you interrogate the velocity profile of a pulmonary vein and you see reversal of the systolic to diastolic waveforms, it's a sign of increased filling pressure. And certainly if you see bilateral anterior B lines, that's very concerning. And you're going to assess the risk to the lungs accordingly. And if there's a moderate to high risk, then you really need to say that the lungs are not fluid tolerant. You need to treat the underlying cause, determine the underlying cause, and really ask yourself, why am I giving this patient fluids? So if the lungs are looking like they're low risk, then the second most important organ is the heart. And so the question of the heart that you really need to ask is the heart near or at the flat portion of the Starling curve, as we've just talked about? And really the only way that you can assess this physiologically is you need to do something to interrogate the heart, and that's usually a mini fluid challenge, or ideally a passive leg raise, because that's fluidless. And what that does is it increases venous return relative to the Starling curve, and then you have to instantly assess the effects. So that's usually requires something like PICO or LIDCO, but with an ultrasound you can look at VTI, and without getting bogged down in the details of dichotomous augmentation points, I think it should be thought of more in terms of a spectrum of risk. Like a 30% VTI augmentation in response to a passive leg raise is much more reassuring than a 15% augmentation, which is certainly much more reassuring than a 5% augmentation in VTI following a passive leg raise. And so if you have a very low augmentation following a passive leg raise or mini fluid challenge, then you really need to say that the heart itself is fluid intolerant. You need to determine the underlying cause and really ask yourself, why do I need to give this patient fluids? And then lastly, you can assess the visceral or the uncivilized organs. Similar line of reasoning could be made for the brain as well, but you're looking for signs of right-sided venous hypertension. So here you can look at the respiratory variation or diameter of the IVC, which could tell you potentially if the central venous pressure is elevated, but also the waveform of the hepatic vein, portal vein pulsatility, intrarenal vein pulsatility. All of these things can give you a sense of how high the pressures are on the right side of the heart. And if the pressures on the right side of the heart are high, then you really need to ask yourself, why am I giving this patient fluids? Determine the underlying cause. So again, you're looking at the left side of the heart, but not really for the heart's sake. It's for the lungs. Here, you're doing a dynamic assessment on the heart itself. And then lastly, looking at the right side of the heart, but not really for the heart's sake. You're actually looking for the visceral organs and the brain's sake. And in the brain, you could throw on a measurement of the optic disc, or if you can do a transcranial Doppler and look at the middle cerebral artery diastolic runoff waveform, you can get some assessments for intracerebral pressure. And so if all of the vital organs look good, then it seems like the benefit of IV fluids probably outweigh the risk and could provide the patient with some rational fluids at this point. Now, these are all cases that are, you can always violate the rules, right? There's no rules in medicine. So there could be situations where you have signs of pulmonary intolerance where you actually would give fluids. So an example that comes to mind is a patient with SCAPE or pulmonary hypertensive emergency, where they may actually come down with pressure, present with pressure natriuresis and being volume down, and once you've corrected the afterload and redistributed the blood from the thorax to the rest of the body, they may actually need a little bit of fluids. Similarly, for the heart, you can have situations where the patient's hypovolemic and has a low diastolic pressure and therefore a low coronary perfusion pressure, and the low coronary perfusion pressure is causing cardiac dysfunction, which shifts the slope of the Starling curve down and to the right. So paradoxically, giving fluids can actually improve coronary perfusion, improve the slope of the Starling curve. And in situation number 3, where you may have a high CVP, where fluids rather than diuretics would be indicated, would be situations like tamponade or high right ventricular afterload, say from auto-PEEP or a pneumothorax, where actually in those situations diminishing preload could be very problematic. So not everything is absolute, as you're all aware. So the objectives of the talk were to differentiate between volume status, volume responsiveness, and volume tolerance, to understand that physiologically volume status and volume responsiveness are dissociated using Guytonian physiology as an explanatory device, and then understand my schema for organ-specific volume tolerance. Here's some other resources you can check out for further reading. Thanks for your attention.